So I've been talking more about homologous recombination. That is a more common pathway that's deficient, and nucleotide excision repair has been shown to be altered in some cancers. I believe bladder cancer is one of the first places it was really shown to be a pathway that's disabled with ERCC2 mutations, and a mutation signature was developed. But before I get to how we stumbled upon NER, once we found these HR deficiency scores, we looked at cell line models that had high HR deficiency scores versus low HR deficiency scores. We validated that they were truly HR deficient using gold standard methods, such as immunofluorescence and response to DNA damaging insults. And then we also showed that they were responsive to some of the drugs that have been approved for HR deficient ovarian and breast cancer, such as PARP inhibitors, that those models were more sensitive to these inhibitors than models that had low HR scores and were presumed to be HR proficient. So that was exciting for us that we were able to translate that. In the context of that validation, we found one cell line that was very sensitive to cisplatin, which is also shown to be synthetic lethal with cancers that are HR deficient. And when we wanted to validate that this was an HR deficient line, we learned that it was HR proficient, but still sensitive to a drug that we, that thought that indicated that there could be some level of DNA repair deficiency. So exclusively sensitive to cisplatin, but HR proficient. And that's where we decided to say, let's look at if this cell line could be NER deficient. And we used a number of methods to learn that this was truly NER deficient. One, in hindsight, seemed an obvious one is we looked at the mutations in this cancer cell line, and it had multiple mutations in different components of NER pathway. That being said, we actually stumbled upon that later. We first looked at whether the gold standard NER assays would detect a deficiency, and we used actually a breast cancer cell line that was known to be NER deficient as a positive control, and we showed that using this assay, you found this gastric cancer cell line to be NER deficient, or at least partially NER deficient, relative to many other gastric cancer cell lines, even HR deficient cell lines that were not deficient in NER. And we did two gold standard tests for NER deficiency, and felt like this was convincing enough to say that this is an NER deficient line, and we then used that bladder cancer signature for NER deficiency, which is really based on having an ERCC2 mutation in bladder cancer, and applied it to gastric and esophageal cancers, and a smaller fraction were above a threshold that was validated in bladder cancer. So I think that's early days for NER deficiency in gastric cancer, but just to say that there's a model that was truly NER deficient and there may be a subset of patients opens up the possibility of a predictive biomarker for therapeutics against NER deficient cancers. I'll keep this answer short. I think if we apply HR deficiency mutation signatures to these patients and see that they're scoring above a threshold, let's say it's the 42 that we used for ovarian cancer, I think those patients, the use either in the setting of a clinical trial or off-label use of a PARP inhibitor could be beneficial to these patients. At minimum, we're enriching for those patients who may respond to PARP inhibitors and platinums that may not be routinely used in gastric cancer, such as cisplatin, which is less often used. More often, we're using oxaliplatin. So these would be the things that I would want to have conversations with clinicians, and if a trial is needed, then potentially doing a clinical trial to really more rigorously examine this. I think one thing that was lacking in our study was we used some patient-derived models. We used the gastric cancer organoid model, but I think more, for the HR deficiency side, the more models that we can show that this is relevant for, like PDX models, patient-derived organoid models, I think the confidence increases that this is something that can be translatable into the clinic. So I think that's not a real conceptual need, that's more rigor to get us towards patients. I would say there's a lot more to learn on the NER deficiency side. What percentage of gastric cancer patients are truly NER deficient? Can we develop models? Can we understand the mechanism? And one aspect of the study that was trying to get at that was using this one model, which I don't think one model is sufficient, but for now, I think it's a good starting point. But we tried to understand the pathways that may be making it susceptible, or why was it so much more susceptible to cisplatin. We found that in addition to more traditional apoptosis induced by chemotherapeutics, we saw another type of cell death, an iron-based cell death called ferroptosis being induced, which we validated at least for this cell line. And so that's an intriguing relationship and something that I would want to learn more about. So if I were to, we in our lab will do this, but I hope others who find the results of our study compelling would want to look into this relationship between NER deficiency, sensitivity to platinums, and maybe this additional mechanism of cell death that's being induced called ferroptosis, either independently thinking about ferroptosis in gastric cancer, is this mechanism of cell death being evoked by different treatments that we're giving, or in the context of NER, why is it being induced and what's the molecular mechanisms, and maybe that will lead to more understanding, for sure, but maybe some therapeutic ideas.